Hello guys, a warm welcome to all of you. The much anticipated NEET-PG got over, and as I looked into the physiology questions asked in this NEET-PG, it looked very simple, straightforward, and majority of them were clinical scenario based questions, that is, it is about the clinical physiology. As I observed, all the questions came from the repeat topics. This is what I repeatedly say, repeat topics will be repeated. So, you need to be very thorough with those repeat topics. So, with that small introduction, we'll straight away move into the questions. Look into this first question. The given graph shows PCO2 and PO2 of the right lung along with the ventilation perfusion ratio. Which point on the graph represents a VQ ratio if there is complete block of the blood supply? And this is because of pulmonary embolism. See clinical physiology. This we discussed in ventilation perfusion ratio lecture. There are points here A, B, C, D, E. What is the answer? I sincerely wish you got all the questions in physiology correct. This question you should have definitely marked correctly. The answer is point E. Yeah, it is point E, this point. Why, sir? For that we have to understand this graph. Very simple one. What is this ventilation perfusion ratio, sir? We are considering useful ventilation, and that useful ventilation is alveolar ventilation. And we also have the perfusion, that is pulmonary circulation. How to calculate this VQ ratio? This alveolar ventilation is the V factor. Perfusion we denote as Q. That is why it is 4 liters per minute divided by 5 liters per minute. Essentially, it is 4 by 5. The normal VQ ratio we always consider 0.8. Okay. The normal VQ ratio is 0.8. Numerator is ventilation, denominator is perfusion, VQ ratio 0.8. Now look into the scenario. Ventilation perfusion ratio 0.8 means it is perfect matching. But there are certain extremes where there is a mismatch. And one important mismatch we are going to consider, no perfusion at all, only ventilation is there. That means our VQ ratio, ventilation is there, but perfusion is not there. In any ratio, when the denominator becomes 0, it totally becomes infinity. That is the question they are asking. Ventilation perfusion ratio, there is no blood. Perfusion is 0. The ratio becomes infinity. Then what about this ventilation, sir? We simply consider this as a wasted ventilation. That means the air is there is no blood for gas exchange. It's a wasted ventilation. And what is this ventilation, sir? I am inspiring air. This inspiring air will be there inside. There is no blood for gas exchange. That means this ventilation is a inspired air. Very important concept. In inspired air, we have the PO2 of around 150 millimeters of mercury, and PCO2, inspired air, it is usually nil. Now the question, why there is no blood? See, this ventilation, this inspired air is in full makeup, waiting for his friend. Who is the friend? The blood flow, the perfusion. But the perfusion is not coming. Why? Because of a traffic jam, roadblock, which commonly happens. There is no perfusion. He is not coming because of a roadblock. And what is this block, sir? No blood flow at all because of our very well known pulmonary embolism. So air is there, blood is missing because of pulmonary embolism. Now let's look into this diagram. This simple ventilation perfusion diagram. X-axis partial pressure of oxygen, Y-axis partial pressure of carbon dioxide. That is why this diagram can be also called as oxygen carbon dioxide diagram. Okay. X-axis partial pressure of oxygen, Y-axis partial pressure of carbon dioxide, oxygen carbon dioxide diagram. Three important points need to be noted. First point, second point, third point. And the graph exactly goes like this. This is what we saw in the graph now they gave in the exam. Now we are drawing that three important points. Now let's look into this point and look for simply the PO2 and PCO2. This PO2 I am getting 150 millimeters of mercury, PCO2 0. It is looking like an inspired air. Why? Because there is no blood here for gas exchange. That is why this is the point of VQ ratio infinity, and that is classically in pulmonary embolism. So what is this point in our graph? It was point E. They asked about pulmonary embolism. Only inspired air is present here, there is no blood flow. PO2 150, PCO2 0, VQ infinity, pulmonary embolism. Look into this point here. Now let's look for the PO2 and PCO2. Here the PO2 comes around 100 millimeters of mercury, PCO2 around 40 millimeters of mercury. This is the normal alveolar air after proper gas exchange. Here the VQ ratio is 0.8 normal. That means this point is normal. Proper gas exchange is happening. No problem with ventilation, no problem with perfusion. PO2 100, PCO2 40. Here the normal VQ ratio of 0.8. Now look into this point. Look for the PO2 and PCO2. Here the PO2 around 40 millimeters of mercury. PCO2 is how much? Around 45 millimeters of mercury. This corresponds to my mixed venous blood. Here the blood is there, but there is no air flow. That is why the VQ ratio here becomes 0. The numerator is 0. There is no air flow. Why? Because of something called as our very well known foreign body obstruction of airways. Okay. Foreign body obstruction of airways, there is no ventilation, VQ ratio is 0. The blood is there, but that blood is mixed venous blood. So if they ask you to choose foreign body obstruction, which point? You should choose this point. There is mixed venous blood, PO2 40, PCO2 45. So foreign body obstruction, this point. Normal VQ ratio, this point. But the question is about pulmonary embolism. That is why it is about the inspired air values. Pulmonary embolism means in our graph point E. So we are choosing this point, point E, pulmonary embolism. If it is about foreign body obstruction, next time they are asking the clinical scenario about foreign body obstruction, it should be this point. Normal is this point. Now pulmonary embolism, it should be point E. Simple. Next question. In the given length tension graph, maximum active tension generated at which point? Any guess? Any idea? A, B, C, D, 4 points are there. What should be the answer? It should be definitely point C. This point, point C. See guys, this is our actin, this is our myosin. For active tension should be maximum, you need optimal overlap. You need optimal overlap of actin and myosin. That should be optimal overlap of actin and myosin. We are clearly seeing at point C, there is optimal overlap between actin and myosin. That's what we are going to discuss. For maximum tension generation, there should be optimal overlap of actin and myosin. Now look into this simple concept first and foremost. Our skeletal muscle is contracting. Contraction means shortening. Shortening means length will change. Contraction means tension will be generated. Shortening means length is changing. Contraction means tension is generated. There is a relationship between length and tension. That's why it is length-tension relationship. Now look into this graph. Beautiful graph. We are going to understand. Very simple. And this is point D. what exactly happens? This is length, this is tension. Look at point D. The tension is minimum, isn't it? The tension is very minimum, or practically nil. There is no tension at all. Why? At point D, this is actin, this is myosin, they are wide apart. If there is no interaction between these two, actin and myosin, how can you generate tension? Point D, the tension is nil or minimum because actin and myosin are wide apart. Now, the next point. Between B and C, we are clearly seeing this is perfect overlap. Okay? This is perfect overlap between myosin and actin. At point B, there is overlap, but it is not perfect. That is why the tension generated maximum. See? Maximum tension. At point C, because perfect overlap of actin and myosin. At point B, there is overlap, but it is not perfect. Now, if you further go down, this is point A, what happens? There is definitely overlap, but not optimal. But not optimal. There is definitely overlap, but it is not optimal. That is why the tension decreases at point A. See, the tension is decreasing at point A. Now, at point D, tension is minimum because actin and myosin are wide apart. C is the point, perfect overlap between actin and myosin, maximum tension. B also, tension is generated, overlap is there, but it is not perfect, point B. What about point A, sir? Overlap is there, but it is not optimal, so the tension decreases. At which point we are getting maximum tension? Point C, because of perfect overlap between actin and myosin. That's why we are choosing point C as the answer here. Next question from environmental physiology. A young man was flying from Delhi to Leh at 3,700 meters from the sea level and started to experience dizziness, nausea, discomfort and headache. This is very important. Headache, something related in the cerebral circulation. Headache. Which of the following mechanism is responsible for the symptoms? Anything to do with bicarbonate, anything to do with H plus ions, anything to do with oxygen. Definitely something to do with decreased PO2 causing cerebral vasodilation, leading to something called as high altitude cerebral edema. So the answer should be option B. Yes, sir. Now, very simple, guys. Effects of hypoxia in lung, it is different. In systemic circulation, it is different. Lung responds to hypoxia by causing vasoconstriction. Systemic circulation like brain respond by causing vasodilation. So the effect of hypoxia are different. In lung, vasoconstriction. In systemic circulations like brain, vasodilation. Both are problematic. In high altitude, it is always the hypoxia that is the culprit. Lung, there is edema, we call high altitude pulmonary edema. In brain, there is edema, we call high altitude cerebral edema. The question is about high altitude cerebral edema. Vasodilation, hypoxia. This vasodilation elevates capillary pressure. But the most important point, the single most important point for development of edema in HACE is this factor. This blood-brain barrier is disrupted, leading to increase in permeability. Increase in permeability and edema. That is why this high altitude cerebral edema is a type of vasogenic edema. Next time they can ask you this question. High altitude cerebral edema, is a vasogenic edema, which means disruption of blood-brain barrier leading to increase in permeability and edema, accumulation of fluid in the interstitial space. So the question, particularly headache, it is about high altitude cerebral edema. Hypoxia causing cerebral vasodilation is the answer. So high altitude cerebral edema is a type of vasogenic edema. Now the next question, again concerned with capillaries. They were very fond of capillaries this time. If there is zero filtration across the capillaries, then what is the interstitial hydrostatic pressure, Pi, they are asking. They are giving lot of other values. To understand them, what is this question about, sir? This question is something about our very well known Starling forces that governs fluid filtration and fluid reabsorption across capillaries. So it is about the Starling forces, and here they are asking to calculate Pi, isn't it? Yes, Pi. The value is definitely -2. We'll come back again. First, let's understand the concept. What are all these Starling forces, sir? They are usually 4 in number. Look very carefully. There are certain forces that favor filtration. There are certain forces that favor reabsorption. Both are in opposite direction. Filtration, reabsorption. Major Starling forces, hydrostatic pressure, oncotic pressure. This hydrostatic pressure is there in capillary interstitium. This oncotic pressure is there in capillary interstitium. That's all. There are two major forces, hydrostatic and oncotic. They can be in capillary, they can be in interstitium. So total there are 4. And these are all the 4 forces. Capillary hydrostatic pressure, Pc. Capillary oncotic pressure, Pi c. Interstitial hydrostatic pressure, Pi, which was asked in this question. Interstitial oncotic pressure, Pi I. Pi denotes oncotic pressure. P denotes hydrostatic pressure. Now, which are all the forces that favor filtration? Capillary hydrostatic pressure favor filtration. Oncotic pressure in the interstitium favor filtration. Which are all the forces that favor reabsorption? Most important, oncotic pressure in the capillaries and hydrostatic pressure in the interstitium favor reabsorption. Now they are asking about this hydrostatic pressure in the interstitium. How to calculate net filtration pressure, sir? Very simple. Forces favor filtration minus forces favor reabsorption. So net filtration pressure equals, what are all the forces favoring filtration? Pc, Pi I. So it should be Pc plus Pi I minus the forces favoring reabsorption. What are all they? Pi c plus Pi. Now in this question they are asking about the Pi, isn't it? Now let's go to the question. Very simple. It should be net filtration pressure equals Pc plus Pi I minus Pi c plus Pi. They are saying the net filtration is 0. 0 filtration. It equals, how much is Pc, sir? This is Pc, 18. How much is Pi I, sir? This is Pi I, 7. Minus, how much is Pi c? This is Pi c, 27 plus Pi. So 0 equals 25 minus 27. So what should be Pi? It should be -2. So 0 equals 25 minus 25. So the Pi here is -2. What is this Pi? Interstitial hydrostatic pressure. That is why we are choosing the answer as -2. I think you answered this question correctly. The answer is interstitial fluid hydrostatic pressure Pi -2 millimeters of mercury. Right guys, now let's move into the next MCQ. In an experimental study of insulin, after glucose administration, blood glucose was brought to 300 milligram per deciliter. That means the blood glucose is elevated. Insulin will be released and maintained at this level. What will happen with insulin in this condition? It is in endocrine physiology. It is totally about the, remember guys, biphasic insulin release. This question is about the biphasic insulin release. That means insulin increased initially and maintained at that level. So the answer should be definitely D. Initially it will increase, later also there will be increase and maintain. What is biphasic release of insulin in response to glucose administration? We are clearly saying there is initial rise, first peak. It is definitely due to release of preformed insulin. That means what? Storage. So there is adequate storage of insulin. So in response to blood glucose rises, immediately we have to tackle that. So whichever in storage, whichever in bank already is mobilized. Release of preformed insulin, that is from the storage sites, that will take care of glucose initially. But that alone is not sufficient. You need some more insulin. That is why there is also later slow and sustained rise. Remember, it is due to additional release of stored insulin and also new formed insulin. Insulin synthesis takes some time. That is why the later rise, slow and sustained rise. Still some additional stored insulin are released, along with that new formed insulin will be released. So initial rise, later sustained elevation and maintain. In response to glucose administration, the first one will be released as the already stored preformed insulin. The later release of insulin, still some more additional release of preformed insulin along with newly formed insulin. That's the answer for this question. This is to take care of the elevated blood glucose levels. Next question. A 25-year-old female has a regular 28-day cycle. Which of these hormonal patterns will be seen during day 21 to 25 of her cycle? That means they are asking you about the luteal phase, the later part. What happens? Definitely there is decreased FSH and LH and increased estrogen and progesterone. Physiology and Ops Gynae. Definitely one question is coming these days from menstrual cycle, especially from this graph. I saw many questions so far. See guys, the timeline is very important. Which is the first hormone to rise? It is always FSH. Look into the diagram. This is FSH, first hormone. The second hormone to rise is none other but estrogen. Look into this graph. This is second, estrogen. The third, luteinizing hormone surge, responsible for ovulation. So definitely third one, luteinizing hormone, LH. And what about fourth, sir? This is for progesterone. So in timeline, FSH is first, estrogen is second, luteinizing hormone is third, progesterone is fourth and last. Especially from the 21st day, they are asking. We are seeing more levels of progesterone and estrogen and very low levels of FSH and LH. So around 21st day, high levels of estrogen and progesterone, low levels of FSH and LH. That is the answer. So menstrual cycle, very important one. If you look into these questions, you definitely know all looked very simple, very straightforward. But remember, I always repeat, it is the repeat topic that is going to get repeated. So please be thorough with that guys, and especially in physiology these days, lot of clinical scenario based questions are coming. So please get yourself ready accordingly. And with that small note, we'll conclude this session and good luck and best wishes. Thank you guys.